Today, I'm going to do a podcast over bone health specifically. We have been finding more and more females with poor bone health at early ages. The recommended screening guidelines recommend to start a DEXA scan around age 65. We're finding women younger and younger with poor bone health. And so I wanted to bring a bone health expert on board to give us better insight on how to address this even decades prior to showing bone loss to help prevent this bone loss, and then hopefully help prevent fragility fractures, which you'll hear that a couple times. And what that means are osteoporotic fractures, where you have a fracture from poor bone mineral density. And he helps provide quality insight, how to prevent these and to develop a lifestyle that's conducive to positive bone health. The guest today is Dr. Doug Lucas. He's been making a lot of content. He has a thriving YouTube channel. He has formed what's called the Osteo Collective, where this is a community of individuals and they provide guidance on how to achieve optimal bone health. We'll have a link to this in the description, as well as a link to his YouTube channel and Instagram in the description. Hope you enjoy. My background is my first job as a nurse practitioner was in orthopedic surgery. And so I was in the operating room with a lot of these fractures, total joints kind of stuff. And then I went into emergency medicine where I did the bulk of my career. And so we see a lot of fractures in the ER, saw them in the operating room, and just how devastating they are to both the patient and even caretakers around them. And now that I've kind of switched to this hormone optimization wellness practice, I want to prevent that as much as we can. And that, is something that we need to be talking about even 10 years prior to that event. And so I'm here with Dr. Doug Lucas. He's graciously agreed to come on and provide some insight into hormones and bone health. And I was going to see if you could just give us a little background on yourself and what you've built with your Osteo Collective.
Yeah, absolutely. Well, yeah, thanks for the opportunity. I always love talking about these topics, especially with someone who knows a lot about hormones, because it's such an important tool for people that are concerned about bone health and osteoporosis. So my background is in orthopedics as well. So you and I were doing some of the same stuff, just not in the same place. So I went through traditional orthopedic training, did a fellowship at Stanford in foot and ankle. And my first practice was really kind of lower extremity driven. Relatively big cases though, deformity, frames, all of the kind of crazy stuff that you see in orthopedics and lower extremity. And then I moved to Asheville from Colorado and did a lot more general work. So this is where I really started treating a ton of hip fractures, lots of osteoporotic driven fragility fractures, and got us a better sense of what was happening in the osteoporosis space, which we can get into. But it's really hard to get care for someone who already has osteoporosis, at least the care that they want. When I left that model about 7 years ago now, I did some additional training through A4M, really started getting interested in longevity, hormone health, optimization, lifestyle, all these things that you and I talk about a lot, and created a practice around it called Optimal Human Health, which eventually was built up, became very osteoporosis specific. And then we sold that to the company LifeMD, which I work at now. And we're building basically the same programs over again, but launching a women's health offering, relaunching our bone health offering, and then we're going to continue to work on the men's health side. They've got a big weight loss program too. So we're building out all those things at LifeMD. And I also have, as you mentioned, the Osteo Collective, which is our community for osteoporosis, people that want to improve their bone health more of in a DIY fashion. So that's where the career has led me to this point where I spend a lot of my time educating on my own YouTube channel, on different podcasts, different platforms, about the importance of understanding bone health, looking at bone health in a different way, which we'll get into, and just educating around early prevention and how critical it is to know what your bone density and quality is like.
Thanks. That's awesome. Yeah. And so you're extremely qualified to give any information for us. And so whenever I started this, I was getting, DEXAs on younger women. I mean, the typical guidelines are to wait till they're 65 or so. And, it just, even if they weren't even symptomatic, just kind of from my own curiosity. They were curious about their bone health as well. And I don't think I have gotten a normal DEXA at even in a mid 50-year-old. And some are just
Yeah.
already, negative 2.9 on their DEXA. And so they're already full blown osteoporosis. And these were women too that didn't even have a difficult menopausal transition. And so I bring on hormones at times for, bone, heart, brain health, even if they gracefully went through the menopausal transition. And that really solidified that, okay, that was the right way to do it. And then, so one, we're finding it earlier and earlier. And then two, just the sheer morbidity that these fragility fractures have on patients. A hip fracture, the stats are always so profound. I've seen, 30 to 50% may die within a year. And of those
Yeah.
50% that live, don't get back to their original mobility. And so that just has such a profound impact on quality of life, health, and everything as a whole. And so I want to prevent that 100% if we can. And I do think that discussion happens years, if not decades, prior. And so I kind of wanted to get your insight on how do we start with prevention for these? Like, what is a good lifestyle for maintaining bone health? And then the follow up, does that change with these women that already have osteopenia or osteoporosis?
Yeah, for sure. So yeah, let's talk about the diagnosis piece first, because as you were noticing, this is what I noticed too. When I started getting into more of like the health span longevity space, you start recommending DEXA earlier and earlier for different reasons, right? For body comp or like whatever, you're looking at visceral fat. And then the bone health piece is sort of just like a secondary. You're like, oh yeah, and your bone density is this. And a lot of these devices, the DEXAs that are specific for body comp, a lot of times they don't give you a specific hip and spine bone mineral density anyway, but they'll give you a whole body bone mineral density, which is not great, but it's something. And I've seen, I don't know how many times, these young athletes, women in their 30s, 40s, and 50s that come in with a DEXA, specifically looking at body comp, and then seeing like, did anybody tell you that you have osteoporosis? And they're like, what do you mean?
Hmm.
Like nobody even mentioned it. They didn't even see it, right? It wasn't what they were looking for. And so my concern around osteoporosis, and the reason why I'm on such a mission to educate around early screening, is that we say, if you look at the numbers, like 200 million people across the globe have osteoporosis. That's known osteoporosis. And with recommendations like
Right.
we have in the US, where the USPSTF is recommending 65 for women and 70 for men, we're not screening the majority of the population. And as you're noticing, as I'm noticing, even the people you would expect to have really good bone density, they don't. And so we have no idea how big of a problem this is. And so we need to be telling people, let's get screened. For women, absolutely, as you're going through perimenopause and menopause, if you're having a conversation around HRT, what are the risks and benefits? You need to know what your bone density is. You can't have that conversation without that data, or at least not accurately. So you really have to know at that point. But I would even argue that we really need to even go forward a couple of more decades. Let's go into your 30s, because so many adults right now are not developing peak bone density, or at least they're developing their peak bone density, but it's not good. And it's because of our sedentary lifestyle of our adolescents, of our teens, of our early adults, right? Highly processed food, poor mineral density in foods, avoiding animal protein, avoiding dairy. All these things are going to lead to poor bone quality. So you need to know what your starting point is, because we get surprised, like the woman you were mentioning in her early 50s, already almost a -3 T score. But where was she in her 40s? Where was she in her 30s? Maybe she started there in her 20s. We have no idea, because we don't have that track record, because we're not screening. So this is why it's really important to screen. And then you can say, okay, well, now I know, as a, let's say, a 40-year-old woman, I finally get my first screen. I'm a decade too late, but here we are. I get my first screen through DEXA or whatever modality, and my bone density is low. Maybe I don't have osteoporosis yet. Maybe my T score is negative, 1, 2, something like that, right? Like it's low, but it's not terrible. I have low bone mass technically. So how does that change? Well, for that woman, we need to have the conversation to say, look, you need to know what's happening with your hormones first and foremost. They're super powerful tools. So if you have dysfunctional cycles, if you're having irregular cycles, if your estrogen is low or progesterone is low, or you ovulate, like all these things matter because you need that cyclic hormone balance in order to maintain bone for cycling women. And then what kind of exercise are you participating in? What kind of diet are you eating? The worse your bone is to start with, the more aggressively we need to lean into the things that we know are going to be good for bone. So many women are so focused on the skinny, right? And this is still true despite some big influencers and this movement of like stronger is better than skinny. I still see women just focusing on being skinny, right? So they live their entire life in this attempted catabolic state. If we're catabolic, meaning we're breaking down, if we're trying to lose fat, we're trying to get skinny, you cannot build muscle and bone effectively. So we need to then say, okay, for this woman who is in this situation where she has low bone density, maybe it's time to actually look at being anabolic. And then, you can pair it with some catabolic, right? Like we can cycle these things. Let's use all the tools that we can to build muscle and bone. And then we can back off, but we can trim up a little bit and you can maintain the shape that you're looking for aesthetically. It doesn't have to be all or nothing, but you can't live your whole life in diet mode. You just can't. It's true for men too, right? So we just need to focus on all the tools that are out there, of which there are many. Happy to get into them. But that's the big thing for me is screen and then understand hormones and then focus on the lifestyle piece.
Yeah, with starting to get into the lifestyle, I've seen, just tons of things that really start moving the needle some, but what are the biggest drivers for you for people to implement?
Yeah, so we have this like pyramid built out, which is probably the same as every like functional medicine treatment program out there. But we have the foundational pieces of the pyramid. And this is, foundation more important. The higher up you go, the less important it is. So foundational pieces would be number one, nutrition. Number two, exercise. Number three, sleep. Number four is, you could call it mindset, you can call it stress, you can call it a lot of different things, but some kind of a mental piece. And that's the foundation. So I'll go through each of those. From a nutrition perspective, again, I just mentioned under eating. I find that so many women are under eating just in general, right? They are just nutrient depleted. Therefore, they are macronutrient depleted and micronutrient depleted. Really hard to maintain bone in that setting. So we recommend that we really focus on protein. We have people track out of the gate and recommend that they aim for anywhere from 0.8 to 1 gram per pound of ideal body weight. And for a lot of my patients, they're underweight. And so we actually say, look, you might weigh 110 pounds, but your ideal body weight's actually 130. And like their head explodes, right? They're like, what? No way. But it has to be of ideal body weight. Otherwise you continue to undershoot. And we say 1 gram per pound because a lot of people that have osteoporosis also have some kind of gut dysfunction. They're not particularly efficient at digesting their protein. And so we kind of probably overshoot it. I think you're fully aware of the data around like the 1.6 grams per kilogram. So like if you go 0.8 grams per pound, you're going to kind of fall into this like the threshold bucket of muscle protein synthesis. Beyond that, from a food perspective, I like to keep it super simple. I'm not here to change anybody's beliefs. If we can just agree that high quality protein, getting adequate calories, and then filling in the micronutrients from whatever your beliefs are around food, that's a great starting point. I have my own opinions and my own beliefs, and I'm happy to talk about them. But if we could just start there, then that's better than probably 90% of the people that are struggling with bone health issues. And then you move on to exercise. Now, exercise is interesting because, again, like my population's a little bit older. So, 70s, 60s, a little bit in the 50s. And they've just over the last 3 decades just been trained like cardio, cardio, cardio. This is the way of the woman. You just do cardio. And if you're lifting weights, you're going to get too bulky. And I mean, we almost see it on social media now where I think so many influencers have figured it out and we kind of even make fun of it right now, but it's still there. Right. I still get women who they start lifting weights and they're like, I don't know, just afraid I'm going to get too big. And I mean, I'm not kidding. I hear it. I still hear it. And I challenge them. I'm saying, prove me wrong. Show me that you're going to get too big because I've never seen it. I've had one woman, she was young, and she just had a kind of an athletic build. And she did develop some pretty impressive delts. And I was like, man, like you got some pretty stacked shoulders.
Yeah,
But outside of her, I've never seen a woman who really put on that much muscle mass. So it's hard. If it were easy, you'd have a bunch of jacked women walking around, and we don't. So focusing on resistance training. And then the piece about bone health that's so critical is impact or simulated impact. Now, for my, 50s, 60s, 70s, 80s women, I'm not talking like, let's not start jumping off of stuff without some kind of training, but some kind of impact, whether it be like a heel drop, could be like more plyometrics, like box jumps or like assisted hanging drops or something like that. But those are advanced maneuvers. So please don't do that without somebody teaching you how to do them correctly. Or you can simulate impact through whole body vibration, through osteogenic loading, like the company's OsteoStrong and Biodensity. Like there's a lot of tools where we can kind of trick the bones into building more bone. And so that needs to be a part of it if we're going to really optimize our bone health. So that's the exercise piece. And then if you get into sleep, I don't know how much we need to dig into sleep. It's important, right? You need a minimum of 8 to 9 hours of actual sleep, which means you probably need a 9 to 10 hour window to sleep. I was just commenting to one of my teams, the Osteo Collective team. My dog was in the background and was just joking, like, I think he sleeps 22 hours a day. Like, it's remarkable, you know? And I'm thinking, how many people do I know that actually have an adequate sleep window? And it's really rare.
Right.
And by sleep window, I mean like dedicated bedtime. They know they're going to get up at a certain time. They're dedicating that 9 to 10 hours so that you can have 8 hours of sleep. Because we talk about 8 hours of sleep, and most people say, cool, I'm going to go to bed at 10, I'm going to get up at 6. Like, no, no, no. If you've ever tracked your sleep, you know that if you have an 8 hour window, you do not have 8 hours of sleep. Even if your sleep is darn near perfect, it's still not 8 hours. So the worse your sleep is, the longer your window needs to be. And then the mindset piece. This is huge. This is complex. This is hard for us to do as providers to understand, like, how do we actually help people with their mindset? Because there are so many different ways that we can self-sabotage. There's so many different ways that we can have too much stress. We can have, too many negative thoughts. We can have too many negative people. Like, this is tough. So we incorporate coaching around this in the community and in our practice because it's just universal that we as humans are going to sabotage ourselves. We are going to be attracted to things that are going to sabotage us along the way. So catching all of those things requires some pretty in-depth conversations and introspection.
I want to get just a little bit of insight on the vibration plates. I mean, I've seen your content on it, but just initially, I'm like, vibration plate's not going to make enough of a difference. How much of an impact do they do, and then how much do you actually have to do? Can I just put my foot on it while I'm watching TV a couple
Yeah.
times a day, or what impact? How do I work that into a normal day with everything else going on?
Yeah, so there's some interesting data here. There's actually a ton of research on whole body vibration, and there's also some devices. I think I have one. Oh, I do. I have like a little local device. I'll grab here in a second. But the whole body vibration, I got into this because they're like Power Plate is a big company that has a lot of products in this space, home products, gym products. And they had reached out to me early on because this is an area where people talk about this a lot. And there's such a huge discrepancy depending on which company we were talking to, which influencer, which expert in the space you're talking to. There's two very different fields within whole body vibration. And so I did a deep dive on the research. I don't know, I have like 6 videos on this on our YouTube channel. And the quick summary is the plate has to do enough to have the impact on the bones that you're looking for. And by enough, I mean it has to move up and down enough so that your body feels it. And it has to do it at the right frequency or speed. And you have to have the right duration. So you have to put all those 3 different metrics together. So the reason why PowerPlate has these devices that are so specific for bone health is because they have been used in and done a lot of the research on this for bone health. So the sweet spot is, and there's too much and too little. The sweet spot is between 2 and 4 millimeters of displacement, meaning the plate moves up and down that much. And the speed needs to be between 30 and 40 hertz. So that's 30 and 40 up and downs per second. That sweet spot over what is usually done over 10 minutes throughout a day or all at once is going to give you the best bang for your buck when it comes to standing on a vibration plate. But even then, there's so much play with as far as like how your body is sitting on the plate. And by sitting, I mean standing. So like if you stand on the plate and you put all your weight on your toes, you're not going to feel much of anything other than a foot massage. If you lean back on your heels, you might notice that your teeth are chattering. It's like, whoa, that's a lot of vibration. So a lot of it has to do with the position too. And you can really, move it around to do kind of whatever you want. And so that's the sweet spot. We find if you look at studies where they go bigger than that, because there's some devices that are more like, 4 millimeters, 5, 6 millimeters of displacement. If you look at those studies, there's one device that shows bigger improvement, but you start to see too many, in my opinion, G's or forces that are going to be put on the body. I think you start running into potential risk. So I don't recommend going that big. And then you also see some of the bigger devices actually not having the effect that we would want to see. So bigger is not better when it comes to this. And then there's the ultra low displacement devices. So these are companies like Juvent, what's the other one? Meradyne. These are these kind of like smaller devices that they have what's called ultra low displacement. And so that is going to be 0.1 to 0.3 millimeters, right? So it's very, very small displacement.
Right.
Micro displacement, another way that I've seen it described. When you stand on these devices, you can feel it, but you don't feel much. And so if you look at the research, they say it's good for bone, but I think they're really misleading people. And if you look at the studies on the population of interest, which is really postmenopausal women standing on the device for 10 minutes or even 20 minutes throughout the day, does it have a positive impact on hip and spine bone mineral density? And the answer is no. But one of the guys, I'm not going to say his name, but one of the guys who's a big advocate for these devices actually started both companies. He is in an academic institution. There's a lot of papers that have been published, I think, are with questionable conclusions and discussions. And so it's a really challenging space for that reason. But all those details of the things that I mentioned around the power plate devices are very specific, and that's why we support that company.
Cool. Yeah, we have we have a big weight loss portion of our clinic, so we're almost prescribing resistance training with every GLP-1, but it is
Great.
almost hard to convince them to actually implement it. And so honestly, I feel like a vibration plate is a little better entry level to get them to start doing something, and then hopefully we can keep
Yeah.
working, and then they do develop a good resistance training regimen later.
Well, the other thing about vibration that's nice too is that, if you look at the research around vibration, whole body vibration, and resistance training, it increases the efficiency of resistance training. So even if they're only willing to do like 10 minutes, 15 minutes, 20 minutes, if you do it on a plate, like if you're doing, let's say you do like, a goblet squat on a plate, you're going to have better results as a result of the plate moving underneath you, but it doesn't really feel like it. So you'll have better efficiency, but it doesn't feel harder, right? You're actually working more, better oxygen consumption, but it doesn't feel any different. In fact, some people report that it feels easier. I don't
Cool.
know that it feels easier, but I do like working out on it whenever I can.
Yeah,
And the other thing I
nice.
love doing on it too, well, there's actually two things. So I like massage, doing like massage on it. Like I have chronically like super tight calves and Achilles tendons. So I'll turn it up to high and just plop my calves on there and just let it like just vibrate. It's kind of like using a percussion hammer, like,
Oh, right,
these
right.
things,
Yeah.
these guys, right? So it's almost like using one of these, but across a really broad platform. And that can be really great for massage and then also stretching. So like I'll sit on it and stretch forward. And it just like there's something about the stretch and the vibration. And I just feel my spine just sort of like melting away around it. And you can
Nice.
get such a good stretch on. So it's a good recovery device too. From a weight loss perspective, also my wife has a weight loss company. She uses them for like lymph flow, and so like helping to like
Oh, nice.
mobilize everything. So I think there's a lot of benefit around whole body vibration. You just have to sort through the noise on what devices are better.
Sure. One of the other lifestyle factors, or I'd say kind of two part to this. One is just weight vest walking, and two, running has surprisingly less effect on the bone than I was expecting. Just literature wise, it seems like running has impact. Vests should increase, load on the bones. But what is the research that you've seen with these, and do you change that at all if they are mainly a runner or just using walking for their only exercise?
Yeah, so walking's great. I tell people like I'm never going to tell anybody not to walk. Right? It is such a good. It's just good to move your body. Is it 8,000 steps or 10,000 steps? I think it's different person to person, but we've got to get out there and move. Our bodies are designed to move. Outside of that, like, what about a weighted vest? Well, obviously they're very popular, especially in the menopause space. You've got people like Mary Claire Haber, just super big advocates. Some other influencers are super big advocates, and what they're saying about these things is not wrong. But they quote the one study in particular that's quoted frequently, and the author, I think the lead author's name is Snow on the paper, and they had an intervention that included weighted vests, and then they had a control group. but the intervention also included exercise. And what they showed is that the intervention group had less bone loss, and this is really common in bone health literature, and it's confusing. They had less bone loss, therefore they said it was somewhere between 2 and 3% of bone mineral density gain. But that's compared to the bone loss of the control group, which lost more bone. They both still lost bone. And I see this a lot in the bone health literature, which is both groups lose bone, but one group lost less. And therefore they look at the delta and they're like, oh, it was, like a 2.3% increase in bone density. No. They did not increase their bone density. They still lost bone. They just lost less bone. Now that's still a win in the right person, right? So,
Right.
slowing down bone loss is good. But how much in that study was from the intervention of exercise, which we also know will have similar results, versus adding in the weighted vest. And so this is the challenge with interpreting research. And it's really frustrating when people say, oh, just go read the papers. Like, it's not that easy to read some of these papers, because you really have to, A, be able to have access to the whole thing and not be behind a paywall. But B, you have to know how to read the methods, how to read the statistics, how to look at the graphs and the figures to really understand what's happening. Because a lot of times the authors, intentionally or not, will kind of skew the discussion to whatever their bias is. This is true in exercise. It's true in hormones. It's really difficult to read these papers. So anyway, that's the thing about weighted vests. I'm not saying I'm against them. I think there's value in them. I just don't know that we really know how much value. I have a weighted vest. I have a rucksack that I wear when I'm walking. My other concern around them is, what about joint health? So from a longevity perspective, as an orthopedic surgeon, I told people, and I bet you did too, hey, if you're overweight and you want to protect your joints, lose 10% of your body weight, all your joints will feel better, right?
Yeah.
It's true. But now we're telling people to take a 10% of your body weight weighted vest, put it on your body, and then exercise. So that's fine, I think, for people who are underweight or at a healthy weight and they have good joints. But if you're already overweight, I wouldn't add more weight. You already have that built in, and you should probably work on getting that less built in. And so I'm just kind of lukewarm on weighted vests. A lot of our patients use them. They like it. I think that's fine. But just know that they're probably not as helpful as some people think. And then what was the other thing you asked?
Running.
Thank you. Not a big fan of running. Now, I never tell a runner not to run, because for them, it's more of probably like a mindset thing, right? Like, this is their release. This is their church. That's fine. But running, it sounds like there's impact. It might feel like there's impact. I know, like, when I run, I feel like it's an impact exercise. But if you look at how much impact is actually happening, if you're measuring the G's, like I mentioned earlier with vibration, if you're measuring the G's, it doesn't get to the threshold needed to actually stimulate bone. It'll be somewhere between 1 and 2 G's. Same with walking. It kind of goes between 0.8 and 1.2. Running's a little bit of a bigger delta, but it's not enough. Like, if you look at, say, like jumping off of, or even a heel drop, it could generate 5 G's, right? 5 multiples of your body weight by doing a heel drop. So running's just not enough. And the negative is it's repetitive, generally going to kind of fall into the chronic cardio category. People are running for too long of a distance at too high of a heart rate. So it ends up being a net negative. It's inflammatory, oxidative stress. Also, runners tend to undereat, just on average, in my experience. So then you have like nutrient deficiency plus over exercising cardio. Then they're also probably not doing resistance training, right? So I find that runners are actually predisposed to osteoporosis. It is associated, long distance running is associated with osteoporosis as a sport. So I'm not a big fan of running from an impact perspective.
And then how does your verbiage or tone change, if you have this female with a negative 2.9 T score versus just say a 1 versus somebody who's at 0?
Yeah. I mean, I love seeing the totally neutral DEXs, right? I mean, it's great. You're like, oh my gosh, you're like, your T score is 0. That's amazing. Good for you. Like, great. So probably this is not going to be the thing that kills you, so maybe measure this again in a couple of years. Let's see what happens over time. But what a great starting point. So then for that person, I would just still want to say, like, okay, well, let's look at, what's your muscle mass, what's your body composition, focus on some other things. For the person who has low bone density, they're the -1.5s, -1.8s. This is a warning shot, because we have to remember too, like, 70% of fragility fractures, quote unquote fragility fractures, actually occur in people who don't have osteoporosis, meaning their T scores are above negative 2.5. 70%. So for that woman that has a negative one something, she is at risk of fracture. Now, it's not a high risk, but what we don't know in that person is what is her bone quality. We have a measure for bone density. We don't have a great metric for bone quality, and fracture risk is a combination of the two. So she might have relatively high fracture risk, but doesn't know it because DEXA doesn't report it. There is a way to measure it, but for most people, they don't know. So I would take that as a warning shot and say, look, we want to slow down this trajectory, assuming you're losing bone. We want to figure out why, build a program around it, and then let's recheck it aggressively every 6 months if you're using an ultrasound device, or every year with DEXA. But let's aggressively look at this and make sure that we're headed in the right direction. There's some bone turnover markers you can use too. And make sure that this is a top priority. And when we talk to people about the community, we bring them in for 12 months at a time, because we say, look, you need to focus on this for the next year. Like, this is your top health priority. Let's do all the things for this for the next year. And that's going to be inclusive of all the lifestyle stuff, hormone optimization. I mean, it's all good, right? But this is the focus. We're going to do this through the lens of bone health for the next 12 months. So that's what I would tell that person is, let's get real specific about what is going to be good for your bones for the next 12 months. And then let's recheck.
Gotcha. And so you've kind of already alluded to the markers of bone turnover, but I'm going to kind of even switch from lifestyle to even a little bit more, for me as a clinician specifically. We've talked about DEXA several times, and we're looking at T scores of the left hip, right hip, lumbar spine. What all are you getting from a DEXA scan whenever, whenever you're first meeting a patient?
Yeah, we use DEXA. We have to use DEXA. It's globally available. It's covered by insurance and Medicare. So we're not going to get away from DEXA anytime soon. But DEXA has flaws. DEXA is a weak, older technology. It's been around for decades. And all it tells us, again, if you're just using DEXA, all it's doing is using X-ray to tell us something about the mineralization of your bone. It's giving us bone density. We look specifically, like you said, lumbar spine, L1 through 4. We look at different aspects of the hip. I'm most interested in the femoral neck, the thing that usually breaks. So we'll use femoral neck as our measure. And a lot of people get confused and they read neck. They're thinking the thing that connects their head to their torso. That's not the neck we're talking about. It's the femoral neck, which is in your hip. And so we're looking at those things, and it's good to know density. But again, it doesn't give you quality. The other things about DEXA that are really good to remember is that DEXA has what's called an LSC, or a least significant change. It's sort of like the margin of error, if you will. The margin of error, if you talk to the DEXA companies, the companies that make these things, they'll say it's somewhere between 2 and 3%. So even if we were to be gracious and say that, okay, I believe you, which I don't, but let's just say we did, and let's just call it 2%. Right? So then the LSC, or the margin of error, is plus or minus 2%. That means that you have to see a change greater than that amount in order for us to know that it isn't just due to variability in the machine. And that's the same machine. If you go from machine to machine, it's worse. It's much bigger. And if you look at other studies that aren't done by the manufacturers, they'll say that the LSC is somewhere between 4% to 6%. So now we're talking about a plus or minus potentially up to 6%. That's a 10% swing. That's a really big number when it comes to bone density. So this is a huge problem, because most people who are on a bone health journey, even if they're doing great, are going to see an improvement of 2-3% over the course of 12 months, maybe 24 months. And if your LSC is 6%, oh man, like, you have to do the same intervention for the next 3 years to see the benefit. Like, this sucks. This is not a good imaging modality for this problem. Now, there are other tools out there. So even through DEXA, there is a software add-on called TBS, or Trabecular Bone Score. TBS is helpful because it tries to look at quality as well, but it's still using the same data. It's still starting with the same two-dimensional X-ray, still looking at mineralization. But they've been able to kind of fine-tune this tool over time. And so it'll divide people into one of 3 groups if you have osteoporosis. Either you have normal bone quality, partially degraded bone, or degraded bone. And it could be helpful if you fall into either the first or the third category. Not really helpful if you fall in the middle category, because that's where most people are, right? They have osteoporosis with partially degraded bone. That doesn't change what I do. It's good to know if you have osteoporosis and good quality bone. That's actually a really nice thing to find. It's also good to know if you have osteopenia and degraded bone, poor quality bone, right? So some of the outliers there is helpful, but in general, I find that most people fall into that same category, osteoporosis, partially degraded bone. Doesn't help me. And then there's another device called a REMS, which is from the company Ecolite out of Italy. And this is a device which is really picking up a lot of steam in the bone health space, but currently in the US, not accepted by insurance or Medicare. So this is a cash pay product. It is an FDA approved imaging device. It looks at bone density and give you a T score like a DEXA, but it'll also give you a quality score called a fragility score. And unlike the TBS, which splits it up into 3 groups, this will split it up from in a range from 0 to 100. So now you can see very fine gradation moving up and down. A little hard to know right now with the research that we have, like what do the small differences mean? Because I have people who are repeating these every 6 months, right? So we can see some subtle changes in the fragility score. But what we see with REMS is that it does change more quickly, and it changes with probably less and less intervention. So I'm really liking the REMS right now. It's not perfect either. We still need more. We need more research. We need more data sets done with different populations. But I really like the REMS in general.
Gotcha. And so that's, you know, how we're looking at bones, getting the bone mineral density. Do you use any biochemical markers of bone turnover like the NTX or CTX? I've seen kind of both of those in the training. CTX for blood, NTX for urine. Are those part of your
Yeah.
workup or monitoring?
Yeah. So I really like the bone turnover markers. The research behind them is pretty good. And most researchers are really leaning on the CTX in blood, the C telepeptide, and then the P1 and P for the building side. You can get them both through serum, through blood. And you can, if you get them at the same time, you get a sense of what's happening with bone turnover, bone metabolism. So what I really like about these is that, you know, the imaging modalities, like I said, REMS, you can see differences at 6 months. DEXA is going to take at least 12, if not more. The bone turnover markers are changing daily. And so that is also a weakness, meaning that you can kind of trick yourself. You can game the system with bone turnover markers if you want to. But if you keep all of the potential variables as consistent as you can, meaning, you know, if you worked out the last time that you had bone turnover markers, work out this time the same amount, the same time period before. I would say don't work out for 2 days before, but whatever it is, right? Do the same thing. If you ate a big meal the day before, eat a big meal the day before. Get them done at the same time. Get them done faster. Like if you're a woman who's cycling, get them done the same day of your cycle. Like you want to control as many variables as possible when you get these bone turnover markers done. And then once you do, then you can start tracking these regularly over time. What we see is that people who are doing the things that we know are good for bone health, we will see very predictable changes. We'll see what I'd use as the ratio between the two. We'll see better bone turnover. So if you look in the research, there are a couple of authors who have started doing this, but essentially what you do is you use the bone building biomarker, the P1 and P, and you put it over CTX adjusted for units. I don't remember the units off the top of my head, but basically you move the decimal point for CTX over three places, and that gives you usually a 2-digit number in P1 and P over a 0.3-digit number of CTX. And then you get a ratio, and that ratio is going to be generally be somewhere between 100 and 300 unless they're on some kind of a drug, and higher is better, more bone building per breakdown. Now, I would love to see better research on this, but we've seen it in a number of intervention studies where they're tracking this. We do see it for people who are gaining bone mineral density. We do see them have better ratios. So I'm clinically convinced that this is working. I've been criticized online by some people who say that there's not enough evidence to say that this is what we should be doing. But my rebuttal to that is, then what else do we do, right? Do we just put our head in the sand and wait and get our next DEXA in 2 years? No. I love using biomarkers where we can. When they fall out of like what we think makes sense. So for example, if someone has really slow bone turnover, we know they're under eating, but like the ratio got better. We're like, no, look, we can't just go off the bone turnover markers. We have to take it into context with the whole picture. So it's not perfect, but that's what we like to use in between. And then, I mean, for people that are being, I want to call them being aggressive. For people that are very concerned, we can do them as frequently as like, you know, every 6 months, you know, twice a quarter, we're getting these drawn, which there's some cost to that. But where I see this really valuable is for people who are coming off of bone drugs. for
Okay.
people who are stopping Prolia, for people who are coming off of an anabolic and not going on an anti-resorptive, right? People who are taking the risk because their endocrinologist told them differently. But people who are doing this, they think they have it handled. Let's look at these bone turnover markers, and you can see if you're failing, your CTX will go through the roof, right? Like you'll start losing bone like crazy, and you can catch it early. You can catch it before the DEXA will pick it up in 12 months after you've already lost, 15% of your bone density, right? So I think there's a lot of value in certain circumstances of using these tools.
That's awesome. Thank you for your insight with those. Because I'm not getting them currently with just my normal hormone stuff. But I do have a few females who are already, diagnosed osteoporosis that I want to be a little bit more aggressive with them. So I'm gonna kind of
Yeah,
start playing
and
with
you got to
them.
be careful. I mean, if you get them out of context, they could be misleading too, right? Like especially like we've kind of looked at this throughout the cycle for cycling women. If you get it, at like the middle of the luteal phase when estrogen is, I guess it comes back up. If you get it, I guess if you got it like day 3, right? That's where a lot of times doctors will measure hormones. If you were to get it like day 3, you would have the lowest estradiol throughout the month, and your CTX is probably pretty high,
Gotcha.
right? But then if you get it day 12, right, through the follicular phase, estradiol rises, so then you're going to have a CTX, which is very low. So it's got to be in context with what's happening for that person. So I definitely wouldn't add, and they're expensive. So I wouldn't add them to every panel. I would do them like as an add-on for people that want to know like what's happening with my bone turnover markers, and then just have very clear recommendations. Like these are all the variables you need to control.
Gotcha. And so, kind of alluding to the sex hormones already. Um, I mean, those are really what I'm implementing first, especially in postmenopausal women, is just getting their hormones back. What role does testosterone, estradiol, progesterone have in just overall bone health?
Yeah, big, right? So I mentioned that pyramid earlier. So foundational stuff is foundational, but right above that's hormone optimization. Now, unfortunately, not everybody's a candidate for using hormones. Lots of different reasons, lots of debate around who should and who shouldn't be using hormones. But if you have the ability to use hormones, it is hands down the biggest tool behind the foundational things I talked about, hands down the best tool for bone health. The reason why I say that is if you look even compared to the bone health drugs like the Prolia, the Reclass, like these big gun drugs, the improvement in bone mineral density in the studies that exist in the right population are very impressive. And this is not something that is a short-term fix, right? The bone health drugs you can only use for a limited period of time. Estradiol you can use, for postmenopausal women until there's a compelling reason not to, or indefinitely. And so this is a long-term fix, which is just as powerful, and in many of the studies, just as powerful as a bone health drug and can be used long-term. So but that is for optimized HRT, which is different than using the lowest dose estradiol patch and hoping that it's doing something good for your bones. So there's nuance to this, but estradiol, hands down, one of the best tools we have. That's why it's FDA approved for prevention of osteoporosis, but not for treatment. Testosterone is not as well studied. Testosterone, I've seen like 2 studies, one intervention study where they added it to an estradiol pellet and oral micronized progesterone. It did outperform the pellet and progesterone alone, but it was a small study, long time ago, and that's about the best we got. Testosterone has been studied in men more, but even then the numbers were small, the studies were short. They showed improvement in bone density in some, but not all, but no fracture risk reduction because they just weren't big enough to detect it. Not the right study design. So we can't say by how much testosterone helps bone, but what we can say is that anecdotally, I'm sure you've seen it, I've seen it, for both women and men that start testosterone therapy who have osteoporosis, boy, it sure gets better.
Yeah,
So
exactly.
I really do think that it is a powerful tool. It's just hard to put numbers on it because the research around testosterone just sucks. And call it what it is. That research sucks. So it's not great. And then progesterone is even worse from a research perspective because it's almost never studied alone. So there isn't a single study that looks at just progesterone therapy for bone health. Like, what does it do? So I look at progesterone like it's always the co-captain to estradiol. Like it's not never. It is sometimes, but it's rarely studied alone. And we know that bone has progesterone receptors, right? We know that the brain, we know that, obviously uterine lining, the breast tissue, like there's progesterone receptors all over the body. So it would make sense that it would have a positive impact, especially in cycling women. We know that that's true. What's the impact for like a postmenopausal woman if she were to just take micronized progesterone alone? Don't know. I think it's good for your bones, but I can't tell you by how much. So the combination though is powerful. We know for cycling women, if they're not ovulating, if they don't develop good progesterone endogenously in their luteal phase, they're going to lose bone. So we know that it's important for bone. I just can't put a number on it.
Sure. With hormone optimization, symptoms guide a lot of my treatment, but I do think like vasomotor symptoms can be controlled with relatively low doses of estradiol. But I've seen stuff where their levels need to be at least 80 to 100 to get optimal, bone health and everything. Are you using numbers to guide, or is there an actual number threshold that makes a difference with bone?
Yeah, so I'm a big fan of measuring. I love looking at biomarkers. Again, I think data really helps us drive decision making. I've been not impressed with how consistent estradiol is from a level by itself. So we used to look at this like we had our range, 60 to 80 was our range. And what we found is that we would have women who had very low levels of estradiol, like 15, 25, and their CTX would drop and we would see them improve. And that's all they could tolerate, right? So we could never ramp it up. They would get symptoms, and the symptoms we couldn't control, or they couldn't, tolerate more progesterone, or like whatever the reason is. And we saw them get better. Similarly, I've seen women that have estradiol levels over 100 doing great from a symptoms of, VSM, GSM perspective, but still losing bone. And so what we've done is we started looking at all of them together and we say, okay, like what is your serum estradiol? What is your FSH? What is your CTX? What is your P1NP? And when you look at all of them together, now we start to understand what's happening at the cellular level on the bone. Because if a woman has, let's do the low example, right? So let's say a woman has a serum estradiol of 20, but her CTX is low. It's under 200 and her FSH has been suppressed. And now her FSH is 20, right? Like I have a hard time telling her that she needs more estradiol, unless she's symptomatic. But looking at those numbers, I'm like, nah, I wouldn't raise it, right? Like, what are we going to do? How are we going to help you more? But and the opposite's true too, right? So a woman has really high estradiol, really high, whatever that means, 100, 120, 150, whatever that is, right? But her CTX is still high, right? Her FSH is still 100. She's not getting it at the serum, at the cellular level, right? There's something happening there. So then I would actually, for that patient, I would ask, like, is this a cream? Did you apply it on the same arm as you had your blood drawn? Like, I don't think that those numbers are real. I feel like something's off. And this is how it helps to guide us. And so there isn't a single estradiol level that we're looking for. It's kind of the big picture. And then we're looking for kind of the outliers, like that last example. Like, I think she probably put cream on her arm and then stuck a needle through it and drew blood. Like I think
Okay.
it's too high.
Can you? I'm not real sure. I'm not following FSH for anything with mine. Why? How is that guiding you?
Yeah, this is kind of an interesting one. I've seen a lot of data around it recently. I learned about FSH when I was learning about there's a whole movement around cyclic hormone therapy for postmenopausal women, right? So all the way from just cycling progesterone, which used to be, standard of care, to actually, a rhythmic protocol where you are actually raising and lowering estradiol and then raising and lowering progesterone. This idea of actually recreating menstruation in postmenopausal women, which is a whole other topic. But in that, they measure frequently estradiol, progesterone, FSH. And the reason for that is that we can get a sense of what's happening at the cellular level if FSH is coming down. Because if you think about what is FSH, follicle stimulating hormone, what is it? Well, it's your cells telling your brain that they want more estrogen, and then your brain sends FSH down to your ovary, a woman's ovaries, not yours, a woman's ovaries, and it's going to stimulate secretion of estradiol. So this is the feedback loop.
Gotcha.
So then if the cells are still starved for estradiol, then FSH is still going to be secreted by the brain, and it's going down and it's talking to the ovaries, but the ovaries aren't listening, right? This is the postmenopausal feedback loop, or broken feedback loop. So then if you apply exogenous estradiol, it's going to have an impact on that feedback loop. And we'll see women's FSH go, from 90, 100 to under 30. And this is when we start to see everything kind of line up, right? We start to see like the lipids get better. Their symptoms are definitely better at that point, right? But it's the early symptoms, like vasomotor symptoms for sure are better. But then they start noticing other things. We're like, man, like my sleep is really good. I'm getting really great deep sleep. I've got so much energy. I feel so much better. My libido, yeah, it was better initially, but man, now it's it's actually really good. Like it's good as it was when I was in my 20s and 30s. Like that's when we start to notice these really profound changes with these hormone levels.
And then on the topic of hormones, I want to talk about thyroid optimization. Like, because we'll frequently try and bring a free T3, from the mid twos to, 4.5 or the upper end of normal. But is thyroid on the upper end or optimization, is that harming bone at all?
Yeah, there was just a study that I recently looked at on this. I think it was a publication from this year, because and this is important because there are, if you just Google it or you ask AI, it'll tell you that um, the drugs, the synthetic drugs, T4 only therapy, is associated with poor bone health, right? If you look at oversuppression of TSH is associated with osteoporosis. So there's these associations that are out there. But what this recent study that I reviewed did is they looked at people who had hypothyroidism who were being treated, which is important because I think a lot of the associations are people that actually have hyperthyroidism
Yeah.
from another cause. Like they have Graves' disease, and they're like, oh, they have osteoporosis. Well, yeah,
Yeah.
but that's not what we're talking about, right? We're talking to people that have hypothyroidism who are being treated with whatever therapy and is that therapy associated with bone loss? And the answer is if you keep their TSH, which isn't my favorite biomarker, but this was an endocrine study. So if you keep their TSH above 0.3, and I forget what the top end was, I think it was like 4 or whatever. But in that broad range, then there was no impact on bone health. If you got, I think there was, I'm trying to spend a minute since I read it, but I think there was a level under 0.3. It was like 0.3 to 0.1, and then it was like ultra suppressed, right? Like the 0.0001. And even in that very low range, there was no negative impact on bone. For those that were highly suppressed, meaning their TSH was essentially unmeasurable, there was within them a lot of heterogeneity, meaning that some of them were losing bone, some of them were not. And I think the reason why we see that is that if you look at some people who are pulling really hard on the thyroid lever, right? They're using big doses of thyroid. I think oftentimes you can cover up other symptoms, you can cover up other things that are going to potentially predispose to bone loss. So I interviewed and I've spoken frequently with a guy, Dr. Robinson. He goes on Instagram by the Sex Docs, and he's a hormone guy, thyroid guy. He's written multiple books on the topic, and they pretty frequently will suppress TSH pretty darn low. He was like, universally in my patients, we do not see bone loss, even though their TSH is highly suppressed. Another Amy Horniman, another friend of mine, she goes by the Thyroid Fixer on Instagram, right? Like her entire practice is thyroid, and very frequently, again, suppressing TSH, being very, very low. Her patients are not losing bone. Why? Because they're optimizing other things, right? They're optimizing hormones. They're optimizing estradiol. They're probably I know John Robinson's optimizing testosterone. He loves testosterone. He's got a brick and mortar clinic, right? So if you optimize the other pieces around it, I don't think you're going to see bone loss. I think if you're pulling really hard on the thyroid lever alone, you might be in danger. And this is why like optimization needs to be a comprehensive look, not just a single lever look.
Yeah. Well, thanks for that, you know, discussion on that, because I've seen, this stuff, but with you, I think it's all been associated with Graves' disease patients and not specific, treatment optimization and like purposely suppression.
Yeah,
We
and
are in,
undiagnosed, right?
we are ending, nearing on an hour, so I may have to get you on a second one for kind of all the other stuff I was gonna cover, but for people to follow you, to get all more insight and deeper understanding of their bone health and just more information on their bone health overall, how do they get a hold of you, or what platforms are you on? Can they follow you?
Yeah, so our biggest platform, hands down, is YouTube. That's where we're putting most of our resources. A lot of this is, as you can tell by my answers, like this is long form content by design. It's
Yep.
hard to do this in 90 seconds or less, right?
Yep.
So this is long form content. YouTube's our primary channel. That's the Dr. Doug Show. Bones, Hormones, and Healthspan is the subtitle there. I'm also on Instagram and Facebook and TikTok and LinkedIn. But I spend most of my time of those platforms. I'm actually answering comments and working with people through Instagram mostly. So that's my preferred platform.
Okay. Well, cool.
Oh,
Well,
and the Osteo Collective. So if you are somebody looking for resources, looking for support, our community called the Osteo Collective is what we built to take a lot of the resources that we built around our bone health program and make them available for our members. So in there we have all these resources. I do a weekly Q&A, either me or a guest, but usually it's me. We have a community where everybody's interacting, all the resources, the ability to buy blood labs, engage with a trainer, for some light virtual training, et cetera. So really cool community called the Osteo Collective, and we'll make sure you have that link too.
awesome. Yeah. Well, I very much appreciate your time. Thanks for coming on.
Yeah, man, it's my pleasure.
Thanks for watching. I didn't get about half of the stuff I wanted to cover out, so we'll definitely have to have a part 2 to get even more insight on supplements and how to use traditional meds such as bisphosphonates or parathyroid analogs and other things, and also how to troubleshoot meds that may make it difficult to achieve bone health, which are like corticosteroid injections, antacid medications. Those can worsen bone quality. And so I'll plan to get him back so we can discuss these further. Like and subscribe for more content. If you have any questions over it, reach out to us. We will have Dr. Doug's YouTube and Osteo Collective links in the description. And so you can follow him and get even more insight if you're interested in going on your own bone health journey. Thanks for watching. Let us know if you have any questions.